Okay, good evening and good afternoon, everybody. Thank you for dialing in today. My name is Sarah DeFeo, and I'm the Director of Scientific Affairs here at the Ovarian Cancer Research Fund. I want to thank you all for joining us as we continue our webinar series for 2012. This entire webinar series has been supported by Genentech, and we want to thank them for their generosity in making this possible. OCRF is the largest organization in the U.S. devoted exclusively to funding ovarian cancer research. Our mission is to fund scientific research that leads to a more effective identification, treatment, and ultimately a cure for ovarian cancer. Since we made our first grant in 1998, we've awarded nearly $45 million in research grants. Before we get started, just a few housekeeping notes. All listeners will be in listen-only mode throughout the presentation. We'll have some time for questions after Ms. Arnold's presentation. So if you think of a question as you're listening, just type it into the Q&A box that you can see on the right-hand side of your screen. Nobody else will be able to see the questions that you ask, and you won't be able to see anybody else's questions, but I will be able to see them. And there's no need to wait until the presentation is over to submit your questions. I do ask that you try to keep your questions as general as possible so that the answers will be useful to everybody who is listening. After the presentation is over, I'll pick some questions for Ms. Arnold to answer. Also, for those of you who are listening to the presentation through your computer, if at any time you have trouble with the audio broadcast and you need to call in with your phone, just click on the button that has a little phone icon on it. It's right above the chat box, and call-in information will pop up on your screen. So, okay, we're very fortunate and pleased to have Angela Arnold with us today. Ms. Arnold is a senior genetic counselor at Memorial Sloan Kettering Cancer Center in New York. She has extensive clinical experience in cancer risk counseling and genetic predisposition to cancer, with a special expertise in gynecologic cancer genetics. She's an active member of the National Society of Genetic Counselors, co-chair of their International Special Interest Group, and co-chair for the Telegenetics Special Interest Group. She also sits on the Phase 1 and Developmental Therapeutics Committees of the Gynecologic Oncology Group. Ms. Arnold has a Bachelor of Science with Honors from the University of Melbourne, Australia, and earned her Master of Science in Human Genetics from Sarah Lawrence College. So, Angela, I will pass the mic over to you, and you can begin.
Great. Thank you very much. I'm sorry, Sarah, how do I get my – it's not asking me to share my desk yet. Can you see me?
Not yet. I made you the presenter. Is there a little box that appeared where you can click and you pull down and it says share my desktop?
No. I'm sorry, everyone.
Hold on. Okay, so Angela, you're on the WebEx screen, right?
Yes, correct.
Okay. I'm changing you, making you the presenter.
Okay.
So passing presenter privileges to Angela. Do you see that box that you saw yesterday when you pull down?
No. There's a box on the right, PPT.
Go over, do you see 3 tabs at the top? Quick Start?
Yep.
Go click on Quick Start. Share my desktop.
That's it. Thank you.
Great. All right.
Okay. We're up and running. Sorry, everyone.
Perfect.
Okay. So thank you to Sarah for organizing today's presentation, and to the Ovarian Cancer Research Fund for asking me to speak today to you all about a topic that I'm very passionate about. And it's also very timely, this presentation, as not only is it Ovarian Cancer Awareness Month, but it is also Hereditary Breast and Ovarian Cancer Week. So thank you again for having me present today. So ovarian cancer is the 5th most common cancer in women. Unfortunately, 1 in 70 women will develop ovarian cancer. Most causes of ovarian cancer, though, are sporadic and occur by chance. However, a proportion of those ovarian cancer cases, about 10%, will be due to inherited mutations within certain cancer genes. The two most common being BRCA1 and BRCA2, which I'm guessing a lot of you have already heard about, and I will go into further about those a little bit later. A little bit of background for those who may not be so familiar with the terminology of a gene and DNA. Within our cells, we have chromosomes. Within our chromosomes, we have our genes, which are made up of our DNA. The DNA is like the recipe of the gene, and the gene follows the instructions of the DNA and makes a genetic protein. And it's the protein that does the function in the body. When we're thinking of a genetic test, we're looking within the DNA of the gene for a mistake or a mutation that stops the gene from functioning properly. And genes can code for many different things, such as our hair color, skin color, eye color, everything about us. But the genes that I'm going to be talking to you about today, a little bit later, are nothing to do with what you look like. They're to do within the cell. Their function is to stop cells becoming cancer. So when we have these inherited mutations, people have an increased likelihood to develop cancers over their lifetime. So back to ovarian cancer. There are many different types of ovarian cancer. The type is determined by what the cells look like under the microscope. So for example, high-grade serous ovarian cancer is the most common ovarian cancer that we do see. And clear cell ovarian cancer would be one of the rarest that we see. Those two types plus another type called endometrioid, they're actually under the umbrella term epithelial ovarian cancer, because they all sort of derive from the surface of the ovary. When we think about ovarian cancer, we can also think about fallopian tube cancer and peritoneal cancer, particularly when we think about the high-grade serous type. The high-grade serous fallopian tube and high-grade serous peritoneal cancers are treated exactly the same as ovarian cancer. So we can think about fallopian tube and peritoneal when we think about ovarian cancer as well. So how do you know if you're at risk for ovarian cancer or if you have an inherited ovarian cancer? Well, a genetic counselor or genetic specialist will be able to take a detailed family history and will be able to make an accurate genetic risk assessment based on the family history as well as the medical history. He or she will be able to order the most appropriate test or tests based on that personal and family history. What is genetic counseling? Well, our title is a little bit misleading because it's not a therapy session. We do have background and we are trained in counseling, but it's really an information teaching session to provide an individual with the information they need to provide informed consent to have a genetic test. When we do a cancer risk assessment, it really is a process, and it should include the assessment of risk using personal and family history information, education and counseling. It should be conducted by a physician or genetic counselor or another provider with expertise in cancer genetics, and it may include genetic testing if desired after the appropriate counseling and consent is obtained. When we think about genetic testing, we ideally wish to test an affected family member first for better interpretation of the results. When possible, as I highlighted before, we would like genetic tests to be ordered by a genetic counselor or genetic specialist because we have an expertise to interpret results. Genetic testing isn't necessarily a yes or a no answer. We occasionally get uncertain or inconclusive results, and we're actually trained specifically to interpret these sometimes misleading results or confusing results. So who should have genetic counseling and maybe lead to genetic testing? Well, any woman with a diagnosis of an epithelial ovarian cancer. So if you recall the types of ovarian cancer I mentioned previously, high-grade serous, clear cell, endometrioid, and this has sort of been determined by a number of groups, including the National Comprehensive Cancer Network, the Society of Gynecologic Oncology, and even insurance companies are jumping on board that this should be offered to these women. In addition, if anyone has not had a diagnosis of ovarian cancer or cancer, but they're concerned about their risk for developing a cancer, particularly ovarian cancer for the case of this presentation, then they would also, get benefit from having genetic counselling as well. So why should you consider genetic testing? Well, genetic testing, it depends on if you've had a cancer diagnosis or not. If you've had a diagnosis of ovarian cancer, then we don't want another cancer to sneak up on us. So genetic testing may actually help clarify your risk for developing a different cancer, for example, breast cancer. If you've never had a diagnosis of cancer, then genetic testing may clarify your risk for developing a cancer at all, be it breast, ovarian, or colon and uterine cancer. Genetic testing may provide options for medical management. So if you've had a diagnosis of ovarian cancer, then genetic testing may help guide therapy. For example, we're now looking at targeted drugs, looking at the biology of tumours, and we're trying to get rid of the bad cells and leave the good cells alone. You may have heard about PARP inhibitors, which are new drugs where the BRCA1 and BRCA2 testing can have a role in eligibility for these trials. I'm not going to go into this in detail today for the sake of time, but if you have specific questions about these drugs, if they're applicable to yourself or the research trials, I would suggest you speak to your medical oncologist or surgeon about these in more detail. Genetic testing may also have implications for family members. If you have had a cancer diagnosis, for example, ovarian cancer diagnosis, and you test positive for a mutation in a cancer syndrome gene, then we have a test to offer other family members to see if they share the risk for inherited cancers. If they do share the risk, then we could recommend particular targeted screening for different organs that are at risk, or we could even recommend risk-reducing surgery. Genetic testing itself, most of the time, is a blood test. You can also use saliva, but we tend, at least at Memorial, to use blood when we can. The turnaround time for the genetic test can range between 1 to 3 to 5 to 6 weeks, depending on the specific test that is ordered, particularly for your individual case. Testing protocols may vary centre to centre. At Memorial Sloan Kettering Cancer Center here in New York, we offer genetic counseling and testing as part of a two-step process. The initial consultation and risk assessment, along with the blood draw, and then the results consultation. But other centers around the country may differ. When we meet with a patient or an individual to discuss genetic testing and we take a detailed family history, we're looking for indicators of a possible hereditary cancer syndrome. Specifically, we're looking for things such as a diagnosis of epithelial ovarian cancer. We're looking for multiple relatives within a family that may have linked cancers, for example, breast and ovarian, or for a different syndrome, colorectal cancer and uterine cancer. We're looking for earlier ages of diagnosis for these cancers, something that's a little bit out of the norm. So, for example, breast cancer in the 20s and 30s would be a little bit unusual, and that would set up a bit of a red flag for a cancer syndrome. If anyone is diagnosed with multiple cancers, so for example, breast and ovarian, or if someone has had bilateral breast cancer, ethnicity can play a role with cancer syndromes. There are certain population groups, particularly the Ashkenazi Jewish, that have certain mutations within genes which are more common within that population group, and that will target what testing we start first. And the presence of other cancers within the family, so male breast cancer, colon cancer, or uterine cancer would be another red flag. So what is going to happen when you meet with a genetic counsellor? As I sort of highlighted before, family history is really important to us. In fact, it's one of the best screening tools that we have. We ask if anyone in your family, your parents, grandparents, siblings, children, aunts and uncles, have had breast, ovarian, uterine, colon cancer, or any other cancers. And we also ask about your ethnicity. As I mentioned previously, where you're from originally may play a role in what testing we offer first. The initial visit will include a medical history, And as I also mentioned previously, the pathology of your cancer can be very important. For example, if someone comes to me and has a high-grade serous ovarian cancer diagnosis, then I'm going to think about testing for the genes called BRCA1 and BRCA2. If someone comes to me that has a diagnosis of endometrioid ovarian or clear cell ovarian cancer, then I'm going to think about another syndrome called Lynch Syndrome. So you can tell that the pathology is really important for targeting our testing of the patient. We confirm and expand the family histories. We discuss the interpretation of our risk assessment to the patient, and we review the genetics of ovarian cancer, and then we discuss and facilitate the genetic testing and what other options there may be, as there may be different tests we may, multiple tests we may offer. This slide is just to show you a little bit about what a family tree looks like. Circles are females, squares are males. Anyone shaded represents a cancer diagnosis. These three types of family trees are similar to what we might come up in a genetic counseling consultation. Unfortunately, cancer is very common. So people usually have a family history of some description. But the reason we go into such detail is it's not always indicative of a cancer syndrome. For example, the pedigree on the left shows one woman in the family with breast cancer at 65. The age of diagnosis is not particularly young than what we'd expect, and there's no other family history of cancer in those generations, so that would indicate a sporadic family. In other words, that cancer probably was due to chance rather than an inherited predisposition. The middle pedigree we do see a lot, unfortunately, but it's when, and it's because cancer is so common, we see two cancers in a family that look like they might be linked, but when we really divulge it more thoroughly, there's lots of relatives who never had cancer, and it's more likely than not that this is not an inherited type of predisposition. Whereas the pedigree on the right is clearly an inherited predisposition. We have multiple female relatives with breast cancer under the age of 50 and ovarian cancer, and that would be indicative of a syndrome. Again, I'm going to highlight how important family history can be and how important it is to be as accurate as possible. And of course, I'm very aware that it's not always possible to be this accurate. But for example, it is not uncommon to get a verbally reported pedigree such as the one on the left, where in this case, this is the patient. On the left here is the paternal aunt, so the father's sister was reported with liver cancer, and father's mother, the grandmother, with stomach. When we revise the pedigree and request the patient to go back and delve a little further, obviously we're lucky because we can't always get the pathology reports, but in this case, we found out the aunt actually had breast cancer in the 40s and the grandmother had ovarian cancer. And as you can see, this has come from the men's side of the family, which also I meant to mention before. We can see these genes coming down male or female side, which not everyone does realize. But in this case, this pedigree here goes to show, and the difference between the two pedigrees, how important verifying family history can be for a risk assessment. When we look at family history, of course, there are limitations. For example, if you have a small family, that may not be as helpful as if someone has a large family. If you don't have many female relatives, that can also be masking, because especially if we're talking about the female cancers, that's not going to be overly helpful. If someone is adopted and doesn't know about their family, and also if in some cases where we don't know the paternity of an individual, that can also mask the risk assessment or limit the risk assessment. When we disclose the results, the structure of the session is usually where we give the results to the patient, we discuss the patient's reaction to the results, we give screening recommendations, discuss risk-reducing surgical options, and make referrals to other physicians. We discuss possible strategies for informing family members about these results, because it's very important information to get out to them. It can be even life-saving sometimes, and we remain available for patients for follow-up and questions as needed. There are limitations to genetic testing too. We can look at a lot of the genes for these mutations that I mentioned before. However, the testing doesn't detect all mutations. It's not 100%. We're not smart enough to look at all the parts of the gene that cause inherited cancers or risk for inherited cancers. So it may not actually rule out inherited risk. And with respect to limitations of genetic testing, there can still be a continued risk for sporadic cancer. So if we rule out inherited cancer for a family, we cannot rule out cancer entirely, unfortunately. We can't take the risk down to zero. There is always a risk of someone developing a sporadic population risk cancer. So there's a number of cancer susceptibility syndromes that do involve ovarian cancer. The main one which you might have heard about is the hereditary breast ovarian cancer syndrome, caused by mutations in the genes called BRCA1 and BRCA2. There is another syndrome I'm going to talk about today briefly, which involves 4 other genes. When mutated or inherited mutations are passed down, can cause another type of inherited ovarian cancer. There are other genes which are now sort of being talked about, which may be associated with an increased risk of ovarian cancer, but they're more, it's more sort of in the research field at the moment, and I'm not going to be talking about these today. But of course, if you have detailed questions about these, you can always meet with a genetic counselor to find out where you lie within these testing or research protocols. So hereditary breast and ovarian cancer syndrome. If you inherit a mutation in BRCA1, then you have an increased lifetime chance for developing breast cancer. You have an increased chance to develop a second primary breast cancer, and you do have an increased chance, it could be up to 50% chance to develop ovarian cancer. There may be other increased risks for other cancers such as prostate or male breast cancer, but if you have a BRCA2 mutation, that is a little bit more elevated in those patients, the risk of male breast cancer and prostate and pancreatic cancers. But individuals with BRCA2 mutations do still have an increased risk for breast cancer and have an increased risk for ovarian cancer. As I mentioned before, there are populations which have what we call founder mutations, so certain mutations that have arisen in certain population groups over thousands of years. Within the Jewish population, there are 3 mutations that are more common, and that is so if someone reports Jewish ancestry, we'll start with those 3 mutations first before we continue on looking at the rest of the gene. So, in the Icelandic population, there is a BRCA2 mutation, and so we look for that first if we had someone of Icelandic descent, and so on. I just wanted to, again, highlight the importance of pathology as well as ethnicity. If someone comes to us with a serous ovarian cancer, then it's up to about a 21% chance they'll have a BRCA mutation, and that's regardless of family history. So based on these figures, at least at Memorial Sloan Kettering, we offer genetic testing to women with serous ovarian cancer, the BRCA1 and 2 testing. And I mean, national guidelines have caught up with this, so most centres probably offer this now, regardless of family history. With Lynch syndrome, the other syndrome I'm going to mention in a moment, the ovarian cancers are of the endometrioid or clear cell type. In other words, non-serous ovarian cancers. So again, pathology of the cancers really helps us target and focus in on what testing we need to offer someone that's most appropriate to them as an individual or family. And about 35 to 40% of women with ovarian cancer of Ashkenazi Jewish or Eastern European descent will have a BRCA mutation. So the ethnicity really does matter. So what do you do if you're found to have a mutation in BRCA1 or 2 to reduce your risk of developing a cancer or another cancer? If you've never developed an ovarian cancer, then there are different risk reduction strategies that we could discuss. Surveillance, which includes transvaginal ultrasound and CA125 blood test. I'm going to go into that more in a moment. We can think of chemoprevention, so using oral contraceptives to reduce your risk of ovarian cancer. Or we could consider risk-reducing surgery to remove the fallopian tubes, which is the salpingo part of that word, and the ovaries, oophorectomy. So salpingo oophorectomy means removal of the fallopian tubes and the ovaries. With respect to breast cancer risk reduction, if someone has had an ovarian cancer diagnosis, then we would recommend they increase their breast screening to breast MRI as well as breast mammogram. And obviously, if someone hasn't had a diagnosis, we would recommend annual mammograms and MRIs as well. We can sometimes talk about chemo prevention, and again, we can talk about risk-reducing surgery to remove breast tissue or to remove the ovaries and fallopian tubes, because in fact that can reduce the risk of breast cancer because you're removing some, hormones, especially if done premenopausally. So when we talk about risk-reducing surgery to remove the fallopian tubes and ovaries, this reduces the risk of ovarian and fallopian tube cancer significantly. There is a remaining risk for primary peritoneal cancer, and the peritoneum is the lining of the abdomen. So it's in close proximity to the fallopian tube and ovarian and the ovaries. Risk-reducing surgery to remove the ovaries and fallopian tubes can occasionally or can sometimes reduce the risk of breast cancer in some individuals, particularly if their ovaries are removed premenopausally. And just briefly, if we're talking about reducing the risk of breast cancer, we can discuss doing risk-reducing bilateral mastectomy to remove as much breast tissue as possible, which does reduce the risk of breast cancer significantly, but it's not completely. And we can also discuss screening with annual mammogram and breast MRI, which actually is our gold standard screening regimen, and it actually is very good at picking up an early breast cancer. So going back to ovarian screening, I know here in New York there's been a lot of media or press about ovarian screening, and I'm assuming the same for around the country. But on a population level, ovarian screening with transvaginal ultrasound and CA-125 blood test is not recommended, as the research has shown that it can cause more harm than good. Recent research has shown that by doing these testing, we're not picking up ovarian cancer any earlier, unfortunately, than you would if you presented to your doctor with the symptoms. And on top of that, the CA-125 is a bit of a finicky marker, and it can go up if you cut yourself, if you have surgery, stress, and it's not a very good predictor of ovarian cancer in an unaffected person. And these screening regimen can actually cause more unnecessary surgical interventions than need be, and those interventions can have their own risks. So we really do not recommend it in the setting of a population risk, or even if you've got one relative with ovarian cancer who's tested negative for BRCA1 and 2, we would not recommend you do any ovarian screening because you've significantly reduced your risk of ovarian by having a negative BRCA1 and 2 test. So the aim really is to educate women and their doctors on the subtle symptoms of this disease. So we're trying to get away from the killer disease or the silent killer. It really isn't. There are signs and symptoms. They do include bloating, pelvic abdominal pain, urinary urgency or frequency, and difficulty eating or feeling full quickly. We're trying to get women to listen to their bodies and to talk to their doctors if they experience any of those symptoms that I mentioned on a daily basis for 2 to 3 weeks. We're also trying to get doctors to listen to you listening to your body. And I'm actually involved with a group called Project Hope, which is a non-profit organization. We've developed brochures and pamphlets for doctors and patients and family members to try and get the information out there about the symptoms and to tell people what they need to do to see if they are at risk for ovarian cancer. Ovarian screening can be used, but we really recommend it really only being used as a bridge to risk-reducing surgery. If we feel they're at inherited risk, so an increased lifetime risk, after they've had a genetic test. So for example, if you're found to have a BRCA mutation, or if we think that you may have one of those undetectable mutations or a really, really strong family history, but we can't find the mutation, then we really think that, and you're too young, for example, to have your ovaries removed, then maybe screening with transvaginal ultrasound and CA-125 blood test can be used up until the time of, after childbearing, and you want to remove those organs that are at risk. So there's another syndrome I wanted to mention because it does involve inherited ovarian cancer, but do note the risk for ovarian cancer in a lifetime for someone with Lynch syndrome is definitely not as high as it is for someone with BRCA1 or 2 mutations, but it is definitely enough to warrant this discussion. In order to have Lynch syndrome, within the families, we usually see colon cancer and endometrial cancer. Usually these cancers are diagnosed under the age of 50, but that's not always the case. That's why a risk assessment with a trained specialist is really important. The other cancers involved in Lynch syndrome include ovarian cancer, specifically of the type called endometrioid or clear cell type. We can also see other cancers such as urinary tract cancers and stomach cancers within these individuals. Lynch syndrome used to be called Hereditary Non-Polyposis Colorectal Cancer, but we now call it Lynch syndrome after Dr. Henry Lynch because although the other title used to be it's very misleading because individuals with Lynch syndrome can develop polyps, but not many, but usually under 10 polyps. And there are other cancers associated, as I mentioned before. So that name was misleading, so we now call it Lynch syndrome. It's important to identify individuals at risk for Lynch syndrome because it allows the appropriate risk reduction for other cancers in affected patients with Lynch, but also family members. So this pie graph shows you how that women with Lynch syndrome have a very high risk to develop a gynecological cancer, mainly uterine, but ovarian as well. But they also have a very high risk to develop colon cancer. So when we see a patient with a clear cell ovarian cancer, we want to, under the age of 50, for example, and we want to work them up for Lynch syndrome because once they're treated for their ovarian cancer, we want to make sure that they do colonoscopies to reduce the risk of colon cancer and also to inform other family members about their risks as well. For Lynch syndrome, there are 4 genes involved in Lynch syndrome. As I mentioned, the risk reduction strategies for Lynch syndrome include colonoscopies, and again, every 1 to 2 years from 20 to 25, and that can depend on the gene, but your genetic counselor would be able to help you determine that, obviously, in more detail. But colonoscopies can actually prevent colon cancer. So this is a very important screening regimen to include for a patient with Lynch syndrome. If a patient with Lynch syndrome has not had a gynecological cancer, then we would recommend endometrial biopsies, perhaps doing transvaginal ultrasound along with CA125 blood tests, or even to consider risk-reducing hysterectomy with their ovaries and fallopian tubes removed. We also would recommend some form of urinary tract screening with just a urine test with cytology and sometimes a renal ultrasound. And we also recommend upper endoscopies to look into the stomach for stomach cancers as well. So again, why is it important to find Lynch syndrome? Well, this graph, you don't need to worry too much about this, but if you don't have a hysterectomy, you've got quite a high chance of developing a gynecological cancer if you have Lynch syndrome. If you don't have a hysterectomy, if you have a hysterectomy, you've got less chance of getting endometrial cancer, but if you don't have a hysterectomy, you have a high chance. With respect to colonoscopy, you've got a better overall survival if you have colonoscopies regularly than if you did not have colonoscopies. And in fact, this is an old slide, and I would expect this percentage is way up closer to 100% because there has been data that has shown that colonoscopies can prevent colon cancer. It's never 100%, but it's pretty close if we start these colonoscopies early enough. So this is one topic that a lot of you probably have questions about. Will genetic testing be covered by my insurance? Well, coverage of genetic testing may vary state to state and country to country. In the United States, genetic counselors can provide the procedure codes, they're also called CPT codes, for genetic tests, so they can contact their insurance companies to find out if their specific plan covers them for genetic counseling and testing. However, you'll usually find that if your personal and family history fit the national guidelines, such as the National Comprehensive Cancer Network guidelines, the test is usually covered, but it's not always the case, so we always encourage patients to check first. But it's kind of exciting because insurance companies are jumping on board with our recommendations and our guidelines about how important it is to have this genetic testing covered and how important it is to have the genetic testing. As of Monday, I should have put 2012, but as of October 1st, 2012, Medicare has agreed to cover full BRCA testing if you meet one of their criteria that is listed in their policy. And the most important criteria for today's presentation, it includes any woman diagnosed with an epithelial, ovarian, fallopian tube, or primary peritoneal cancer. So we're really happy in the genetics world about this progress with the insurance companies, and I'm sure a lot of other insurance companies are going to jump on board soon too. I'm going to touch a little bit about insurance discrimination, but I'm not going to go into too much detail. But the Genetic Information Non-Discrimination Act protects patients, and it means that insurance companies and employees are not allowed to discriminate based on genetic information. This does not cover you for life insurance, but it does cover you for employment and health insurance. So challenges for the future. Can we better identify individuals at risk for ovarian cancer, as well as better determine the timing and magnitude of those risks? Can we make improvements in ovarian cancer screening to allow this to become a viable alternative to risk reduction surgery? And we really would love there to be a screening tool out there, and I know we're working on it. We really are. So I thought I'd give you some resources about today's presentation. The National Society of Genetic Counselors is our national society, which includes a Find a Counsellor section. And so if you want to find someone local to you, you can search by zip code, and you can find your local genetic counselor or genetic center, and hopefully there is someone that's local to you. There are other groups out there that are involved in information about ovarian cancer risk and inherited risk. That includes Facing Our Risk of Cancer Empowered, Be Bright Pink, Project Hope, and of course the Ovarian Cancer Research Fund. And I want to thank the Ovarian Cancer Research Fund for asking me to speak today about this topic, and thank you all for listening. And as I said, if you want to contact your genetic counselor, go to the NSGC website, and if anyone is in New York or is local to New York, here's the number for us at Memorial if you want to make an appointment to be seen. So thank you very much.
Thank you so much, Angela, for really great presentation, very clear and very thorough. Lots of really helpful information there. We do have a few questions.
Okay.
We've got a few minutes here.
Of course.
First, and this is just sort of my question based on what a few people have said, can you talk a little bit more about why every woman with an ovarian cancer diagnosis should consider counseling and perhaps testing, regardless of their family history?
Okay.
I think that many people think that, well, even if, I have an ovarian cancer diagnosis, I have no family history of it, if it's just me. And so I think that may be a bit of a surprise to some people.
Of course. No, that's a really, really good question. And I'll go back to this slide that I mentioned before. So research has shown that if someone is diagnosed with a serous ovarian cancer, more likely the high-grade serous type of ovarian cancer, up to about 21% of those patients will have a BRCA2 mutation, even if they don't have a family history. So we feel that's pretty high. I mean, look, it's still an 80% chance they won't. But I guess what I'm trying to say is, even just based on that possible 20% chance, it's important to be tested because, number one, once you get successfully treated from your ovarian cancer, we don't want breast cancer to sneak up on us. And so if you happen to be that part of that 20%, then we want to make sure and even if it's unexpected, we want to pick up your risk for breast cancer that you may not have thought you're at risk for, and do extra breast screening such as breast MRIs, and make sure you do your annual mammograms as well. Also, if you're in that 20% of the unexpected families, and we definitely do get these. I mean, I know I'm sort of in a center that tests a lot of these patients, but I've definitely had families which have surprised me. So not only are we picking up their risk for breast cancer, but we're also giving their medical oncologists possible future medical management options, such as possibility of being enrolled in research trials for these targeted therapies, such as the PARP inhibitors. And, you know, we're trying, as I said, we're trying to work on looking at the tumors, and a lot of this genetic testing, although we're mainly thinking inherited at the moment, but we're looking at the BRCA mutation carriers and seeing if they respond better to one treatment versus another treatment, and also non-carriers if they respond better to one treatment versus another treatment. Does that answer everyone's question?
That's very helpful. Thank you. A few people asked this question. At what age would you advise a young woman whose mother has a known BRCA mutation to undergo testing?
So sorry, say that again. If someone?
At what age would you advise a young woman, someone whose mother has a known BRCA mutation, to undergo testing? So at what point?
Okay. At what point? That's a really, really good question, and we do actually get that a lot. So when we're thinking about these inherited predispositions due to BRCA1 and BRCA2, the age of onset for the earliest cancers that we tend to see is really the mid-20s, and that's like the very earliest. Our screening in a woman who's got a mutation in BRCA1 and 2 starts at the age of 25, where we would offer breast MRI. That is the earliest we do any form of screening for a person with a known BRCA mutation. We wouldn't start any ovarian screening until about 35. So that's why I'm using 25 as the cutoff at this point. Based on the age that we'd start screening an unaffected woman for breast cancer, we think that around, you know, early 20s or mid-20s is a really good time to come for the genetic counseling before you have the test. In a young woman, and I didn't touch on this, but I'm glad you asked, in a young woman, someone who's, you know, just developing, and we don't feel that testing anyone under the age of 20 or even in the, you know, early 20s is very beneficial because they've got a lot going on socially, or, you know, they're going to college, breasts have developed or developing. They're not going to be able to do anything proactively about their risk until 25. So we sort of keep it around the age of 25. At least that's what our recommendation is at Memorial. Another thing to add with the young women being tested, we also have a psychologist that we work with. And so sometimes that two-step might turn into a three-step protocol, because we're very conscious that a young woman hearing about their breast cancer risk, lifetime risk, and their lifetime risk for ovarian cancer is a lot of information, and that, I guess, is where a lot of the counseling comes in. So we have a really good team that we work with to test these young women at the appropriate time when they're ready for that information. We definitely do not test children. There's no need. It's an adult onset condition, and it's when they are able to make an informed decision on their own.
Okay, gotcha. Okay, two questions I'll ask together that are kind of nitty-gritty questions. After you get tested, how long do you typically have to wait to get results? And do you, in terms of the blood tests, do you test for multiple mutations with one blood test? Is it multiple blood draws? Okay,
no, that's a very good question. So the wait times between getting tested and the results can vary center to center. It sort of really depends on that. I know here, like, depending on the urgency to get the results back, because sometimes the results, especially for someone with, for example, breast cancer, who's trying to make surgical decisions, we can get the turnaround time quite quickly. But sometimes there's a wait time of 2 weeks, sometimes 3 weeks, or sometimes longer. I find here at Memorial, where I see patients newly diagnosed with ovarian cancer here in my office, and I find that, you know, there's no urgency for the results. It's not going to affect them clinically right there and then. So some of the patients actually wait a couple of weeks longer so they can meet with the physician to get the results. So it really does vary. With respect to the blood test, it's usually one blood draw, but depending on the number of steps you need to have. So for example, if you're Ashkenazi Jewish, we can probably do one part with one blood, and we might have to do a second blood draw. It sort of depends on, at least here at Memorial, what part you're doing, but mainly it should just be one blood test. And you are looking within the whole entire gene for all different types of mutations And again, depending on your ethnicity, we might target a couple specific ones first, and if those are negative, we continue looking at the gene. I liken it to spell checking the gene. So if you picture a gene like a recipe, the DNA is the recipe of the gene, you are spell checking the recipe to see if there's a spelling mistake in there or a mutation. And it looks for all different types. Does that answer the question?
Yep, thank you. Here's a question. Do you have any tips for how to track down medical history information? It's clear from what you said that information is really, really important.
Yep,
Someone is wondering, how do people find this information if it's not readily available?
So again, yes, in a perfect world, I would love to be able to get pathology reports, from all of my patients' relatives who report a family history of cancer, and I'm obviously very aware that that's not always going to be possible. However, you'd be very surprised. I managed to get some tissue off a patient from 1988 because she happened to be here at Memorial, and we keep samples and tissues for a very long time, and we keep our records for a very long time. But not all hospitals do that. What we normally recommend is we recommend that patients contact wherever their relative had surgery or were treated. They can contact either the medical record department or the surgical pathology department to get pathology reports from an individual's cancer. Death certificates can help sometimes if they're specific, but not always, because sometimes the specific pathology isn't noted. So ideally, if you go to the surgical pathology department of the hospital that your relative was treated or had surgery at, they should be able to provide you with records from many, many years back. But of course, sometimes that isn't always, possible.
Right. Okay, that's very helpful, though.
Yeah.
Yeah. Okay, probably our last question here. Beyond hereditary breast and ovarian cancer and Lynch syndrome, the stuff you talked about, what other diseases do people seek out genetic counseling and testing for, including diseases other than cancers?
Oh, gosh, unfortunately, there's many, many, many things. Like, for example, I'm thinking of like Tay-Sachs disease, Gaucher disease. In the Jewish population, those are pretty common. Cystic fibrosis. If you've got a family history of mental retardation or children, dysmorphic children that don't look right, there are definitely chromosome tests you can do. Genetic counseling, actually, from when I started, it's grown in leaps and bounds. There used to be prenatal genetic counselors and cancer genetic counselors, and that was it. Nowadays, we have cardiac genetic counselors. We have reproductive genetic counselors who deal with the sort of the IVF situations. We have prenatal counselors. We have cancer counselors. We have so many different types. They have counselors who specialize in neurology, so Alzheimer's disease and other things like that. It's pretty broad now, but there's a lot of people out there, and there's a lot of us out there doing many different things.
Okay, thank you very much. I think we'll end it there. Before I just kind of wrap up, Angela, someone asked if you could show the slide with the symptoms again. So
of course, I think I saw that pop up.
Yeah, it's in there. If you could pull that up.
There we are.
So thank you all. I want to thank Angela again for her excellent presentation today, and I want to thank all of our listeners for calling in. Our webinar series will be back in October. On October 23rd, we'll hear from Dr. Molly Brewer, who's a GYN oncologist up at the University of Connecticut, and she'll be giving a really interesting presentation on palliative care. So stay tuned for details on that. Please take a minute to fill out the survey that will appear on your screen at the conclusion of the event, because your feedback is really important and helpful to us. And for more information about OCRF and, of course, lots of information about ovarian cancer, you can always visit our website at www.ocrf.org. So that's it, everybody. Thank you again, and have a great evening.
Thank you.